health equity, everybody with the same access. So even before the pandemic, the disproportionate health outcomes for certain groups was well known, particularly the social determinants of health were impacting those groups and communities that were disenfranchised. And this next session is going to be exploring all of those topics. It's my pleasure to welcome on moderator Stephanie Hare. And she's an independent researcher, a broadcaster and author, soon to be book coming out called Technology Ethics. It's over to you, Stephanie.
Thank you so much. I am joined by two guests who are both real doctors, as opposed to a social science doctor. And we are going to be having a rollicking transatlantic conversation. We are based in London and in San Diego. We've got a Brit and an American and a dual citizen. So hopefully we should cover between all of those extremes some pretty interesting topics about health equity. So without further ado, I'd like to bring in our two speakers, please. Now, I'm going to let them introduce themselves. So Winta, I'd love for you to go first. You're coming from the West Coast. Thanks for getting up early. Tell us who you are, what you do, and one line about what healthcare equity means to you.
Great. Thanks for this opportunity. Mehtsun. I'm a cancer surgeon and health policy researcher. I'm actually based out of Boston, Mass General Brigham, and at the Dana-Farber Cancer Institute. But I'm here in San Diego because I'll be taking a job here, and so I'm house hunting. I am thrilled to be here. Health equity is a real passion of mine, and I think when we say everyone with equal access, I would say it's more than just access, and I would say everyone with the same boat, and I'll explain that line a little bit later. And the boat is more than just access.
Thank you so much. And now for our second doctor, Ahmed. Please tell us who you are, what you do, and in one word or one phrase, rather, what you think healthcare equity means.
Good afternoon. Thank you for the invitation. So I'm a consultant radiologist at Chelsea and Westminster Hospital, but I've also been leading on aspects of the pandemic response here at NHS England, particularly around the impact of COVID-19 on ethnic minority staff. And in terms of health equity, well, I would say it's access and outcomes, and how we achieve both of those things, importantly for all segments of our population.
Thank you, and thank you both. Now, I thought it would be fun for us to divide this talk into three parts, as all good doctors might. So, diagnosis of the problem, treatments of the problem, and then we will end on an uplifting prognosis of the problem, because unfortunately, as admirable a goal as healthcare equity is, in reality, it's not often achieved. That was true before the pandemic. The pandemic has perhaps thrown that into even starker relief. And I wanted to invite both of you to reflect, not just in terms of what you've seen in terms of diagnosing the problem, but also what you've experienced. Because I think so many of the people who will be watching this have not experienced the pandemic from your point of view as frontline healthcare workers. So over to you. I'm not sure which one of you would like to start. Feel free to jump in.
Sure. I mean, I can start, Naeem, if you're okay with it. If I could just be honest, I think I'll just say it was a shit show. COVID-19 was a shit show, and we all experienced it. I apologize for cursing in advance, but it was a storm that everybody experienced, and it was pretty devastating. I was a first-year fellow, and in training, and it was very difficult. We didn't know what we were dealing with. We were making decisions in real time, and I'll just say that for now. I think that it was unbelievably humbling. And as a frontline worker who saw a lot of death and dying, it was pretty devastating to see patients go through that, to not know how to treat them, and to develop treatment strategies in real time. I don't think anybody, I've never experienced that. I think few people have. It was a lot.
Thank you so much. Naeem, any further thoughts from your side? Also bearing in mind that you were wearing two hats in this pandemic, not only as a radiologist, but the job that you were describing me to before of how to prepare NHS staff and risk profiles. It'd be great to hear more for the rest of the audience.
Yeah, so I mean, Winta described it very eloquently as it being a storm. I would further that in saying we were all in the same storm, but we were all in different boats, definitely in that storm. And one of the things for me on a personal level was actually, as a doctor beginning working within the hospitals and dealing with the pandemic, was that actually coming home at night and turning on your TV and looking at the people. And at that time, unfortunately, there were colleagues who had died in service from as frontline healthcare workers, and looking at the faces of not just the healthcare workers, but people in the community, and looking at them. And what you see reflecting back is people that look like you, look like your friends, and look like your family. And that feeling is something that is indescribable and that will stay with me for a very long time. The added feeling of, which was unique, was that actually going into work, and all my colleagues across all healthcare systems, we go into work every day wanting to do the very best for our patients. But here you go home with the worry that actually you might be going into work to save one person's life, but you come home and you might be bringing something with you that will cause, at the very least, one of your own family members to become sick, and at the worst, actually die. And that completely changed everything for me. So a typical day for me would be that I would go into work, with this fear that actually, I'm at increased risk of contracting and having a poor outcome from this. But then going home and knowing that I live with family members that I might go and pass something on. So I would be at the door, then taking all my clothes off frantically, and then running up into the shower and getting washed. And then what happened is, after that, is that I just had to isolate myself. So I isolated myself in the loft and was talking to my family through the iPhone, and all of these things were so poignant. The fact that actually technology, which was there to make us all feel so close together, at that point we were in the same house, and wow. and feeling actually so far away from them. So I have two kids who just, who couldn't understand why they couldn't hug their dad, and actually coming home and telling them, running away and from them, was just circumstances that you could never ever imagine. And so the personal experience for me, and for so many of my colleagues, I know Winta and everyone else across the world, of COVID and responding to it, has been something that I'm not afraid to say is going to be really scarring. Yes. And then you have said, in terms of the national response. And so the second part of that was that I was involved, in our national response. It's a very simple mission. How do I get, and how do we as a team get as many people of our fellow colleagues as safe as possible? And one of those things there was looking at ethnicity as somehow putting someone at greater risk. And there's lots of underlying factors for that. But I think what people found, some people found difficult and challenging, was that as doctors, as people in the healthcare profession, if you say obesity, hypertension, high blood pressure, diabetes, etc., as putting you at higher risk, then you say ethnicity, people think, that's a difficult thing to grapple with. But that's the argument we had to make, and say, look, there are portions of the population and portions of our workforce that are at greater risk. What the underlying issues, we can deal with that. But at the moment, we know enough to then to act on this, and we need to act quickly. And then that brings up loads of other things that you feel And colleagues have said to me, how do I leave my colleagues behind? Or, I don't want to be seen as any different to them. I don't, we've come in and we're all working together on all these things. So it's just all of these emotions, both within the workplace and without, at home as well. And then to amplify all of that, that, Winta, I'm sure it's the same for you, is that in a community where not many people are healthcare professionals, right? You then suddenly become the reference point
Yes.
for the community, especially when you have something like COVID, where people, are finding out everyone's finding out for the first time. And then your phone is just going off and people are calling you, asking you for advice. What do I do? This has happened. And you're carrying all of that emotional responsibility, not burden, responsibility, because we have a responsibility to our communities, and having to deal with that. So, I'm hoping, I've said a lot, but in terms of these were all of the things that are just flying around your head at the time and continue to do so. And I don't, unfortunately, it doesn't seem that it's closing anytime soon, although we're in a much better place.
Winta, it'd be great, having heard Naeem's discussion of what it was like here in the UK, to compare and contrast a bit with your experience based in the United States. So we've talked a bit about pre-existing health conditions that people might have had that could have made them more vulnerable to COVID. We've talked about personal characteristics, and it might be their age, it might be ethnicity, it might be all sorts of stuff. And obviously the very real risk factor of one personal characteristic that puts you at higher risk is being a frontline healthcare worker. And again, the very moving experience that we just heard of what it meant for a doctor here in the UK to treat other people and the sacrifices he was having to make at home. Just, can you paint that picture for us a bit in the US context?
Sure. I think Naeem nailed it. I mean, we were getting hit from all sides, hit at the hospital, scared of COVID, scared that we were going to kill our families. I mean, I'm a single mother. I have a 2-year-old. I shipped him to my parents. My mom has metastatic breast cancer. She's on chronic chemotherapy. And I was like, I can't see my family. 6 months, no family, and that is hard because they are my support structure. They're my only support structure. Right. So it's like I'm alone in Boston, on the front line. I have to FaceTime to see my son. I mean, I don't know which one's worse, Naeem. I think, FaceTiming your kids in your house might be worse. That's even worse. You know what I mean? And I think, God bless FaceTime, to be honest, because if there wasn't FaceTime, I wouldn't have a relationship with my family. And so I totally agree with that sentiment. And I totally agree that, I was definitely the 911 call that everybody made, when they were worried about everything during that time, and the questions, and, and we didn't know the answers. And, people don't like hearing doctors don't know the answers, right? That does not feel good, right? And so, I think that was hard to navigate. And I also think, you're right that even within the hospitals, we were trying to mobilize. I mean, I had the fortune of being at Mass General. I mean, Mass General is, one of the best hospitals in the country, in the world, actually. And I mean, we didn't have a mask shortage because, the Patriots, went to China and got us some freaking masks. That's what it took, but it was, I mean, that's a privilege, right? Like, that's a privilege that we never even remotely experienced the mask shortage. And, the way that I have to give Mass General credit. The way that they mobilized the whole hospital was pretty damn impressive. And I never had to worry about Mass. And we had adequate supplies. Everybody mobilized, the entire hospital. Attendings came and took call, and people showed up in the ICU. The nurses showed up. Everybody just showed up. And so I will credit them with an excellent COVID response. And the Mass General Brigham system, but then that's because they're an affluent, well-resourced hospital. And I can't agree with you more. I mean, I think I exactly was going to use that parallel, Naeem, about we all got the same storm, but we all had different boats. And that's the note I wanted to say. And I the boat contains a lot of things. And the boat with COVID was social determinants and structural racism. I mean, that is the truth. And Some people got boats that had, that were motorized and had sails and were, really souped up. And other people got the rinky dinky boat that basically would break with any type of, insult. And, nothing you can do will change the outcome of that passenger in those boats, right? And so if you think as the boat as social determinants and structural racism, the mechanism of disparities of COVID comes kind of threefold. You can think about the mechanisms of disease that Naeem talked about: obesity, hypertension. You can talk about that is a result of a couple of things: disparities in exposure to the virus, disparities in susceptibility to the virus, and disparities in access and treatment. And those are the mechanisms by which there was a disproportionate burden of illness and death from COVID-19 in communities that look like me and Naeem. I mean, I was shocked by this number. I heard it from Jose Figueroa. In 2020, Black males lost 3 years of life in 6 months. Let's think about that a little bit. Okay. Hispanic males in America lost about 4 years of life in 6 months. I mean, this is real data. This is not, this is not made up. These are numbers. We want to talk about cases, hospitalizations, and death, relative to white people in America. American and Native Indian Americans had 3.5 times hospitalizations, 2.4 times the death. This is what we did in our country. We didn't show up for everybody. And where you got treatment, what neighborhood you lived in, that, dictated the boats you got. And that just shouldn't be the case. We should be able to give everybody the same boat. And, I'm proud of the hospital that I got to participate with. I'm proud of the hospital that I got to be a COVID doctor in. But, God, there were so many people that were not fortunate enough to be Mass General Brigham patients, and they got the short stick. And, I have a physician friend who lost both her parents to COVID in community hospitals. Both of her parents died, a Black woman. There are different boats. And, I was luckily in an institution where I was adequately resourced to do the job that I needed to do. But even in those institutions, sometimes people get different boats, and I think that if, we really need to talk about social determinants and structural racism. That is a real propagation of different outcomes for patients.
Can I ask you to expand on social determinants for people who might not be familiar with that term? How do doctors see that and factor that into healthcare?
Sure. So basic social determinants: education, access and quality, economic stability, social and community contract, who's around you, how will they show up for you, neighborhood and built environment. And then you have healthcare access and quality. I think of those as being the social determinants. It's not just a function of, obesity and hypertension. Where you went to school, how literate you are, your ability to get agency in a system, the economic stability that you have, there's so many people, who chose not to go to the hospital when they had, symptoms of chest pain, and because they were wary of going to the hospital because they were wary of getting COVID. This is even after the height of the pandemic. This is even today. People are still reluctant to go to hospitals for real issues and problems. I mean, we are not out of this pandemic on many levels, and there's also massive mistrust of medicine right now across the entire spectrum. I think that we really have to establish trust in medicine again, because there's a whole movement of anti-science and anti-medicine that's going on right now that is scary. There are people that are not coming to see doctors because they think that we're using 5G to kill them. I mean, that is the world that we're living in. This is 2021. That's crazy, but it's the truth.
I know. One thing that I wanted to ask, is we've had a question come in that I thought we could weave in quite naturally at this point in our discussion, is whether there's any point in even talking about equality of access in countries that don't have a free at the point of use health service. And that's a great way of kind of teasing out the British versus American example. But of course, this is valid as a comparison around the world. and we've talked about this last week of healthcare as a human right. What happens if you live in a country where healthcare isn't a human right? It's like a function of capitalism, politics, however you want to play it. Maybe Naeem, given that you represent the NHS, maybe you can take that first.
Well, I would say that even, and definitely, I think we'll all be advocates of universal healthcare. That's something that I feel really strongly about. But I think that even with the access free at the point of use, there's still work to do, and we still have disparities that need to be addressed. Certainly, I think we're definitely in a much better place where people don't have to go in and worry about the size of their wallet when they're in need. I think that goes without saying. But I do think that there is obviously ground that still needs to be covered, and COVID has shone us a bright light on those inequalities which need to be addressed.
And I guess that links into what Winta was saying as well, of people feeling that they can't come to the hospital. That was a case in the United States even before the pandemic, because for some people, going to the hospital is a one-way ticket to bankruptcy in the United States, right? Sometimes even if you have health insurance, it can be. So that's another thing, I guess, is as we move from diagnosis of the problem into treatment and eventual prognosis, that we end on a high, how to improve that in both countries. So is everything hunky-dory here in the NHS and in the United Kingdom because we have free healthcare at the point of access? Is there hope to improve the United States and indeed other countries?
I mean, for us, look, I think one of the case studies which I say that should be highlighted everywhere has been our vaccination drive here in the NHS, which has been amazing. And I think one of the things that's underlying that is the diversity and actually the leadership of people that have led it. So from Jewish to Muslim to Hindu leaders, getting behind the program and ensuring that it taps into our communities and those messages reach all parts of the communities has been so important. There's still work to do, but I think that has been a number one kind of highlight in very many kind of lowlights of what's happened over the course of this pandemic. And that's also shown us actually the importance of diversity in our leadership, and also having, I think I'm hoping going forward, and I know this is going into prognosis, is that we recognize that we can no longer have a transactional relationship with our communities, right? What happened here is we realized that the success of the vaccination program may be undermined if certain communities don't get vaccinated. And suddenly that brought a call to arms to everyone to say, you know what, we need to go out and get these communities and get them vaccinated. What if we had that similar level of intensity throughout the course of the year or throughout the time, not just now where we're saying actually all our efforts might be undermined if certain communities don't get it. So I really want to see that going forward as being a thread that we continue to that we continue to develop. The other thing is what we learned was, in fact, in some of the communities that we describe as vaccine hesitant, I would say it's institutional mistrust, right? There are people that still, as Winta said, do not trust both the healthcare professionals, healthcare institutions, and we need to continue to do more in terms of getting messages to them, building trust with those communities going forward. And the last point is, which we've learned, is the messenger is sometimes more important, or is more important than the message itself. Mm-hmm. And actually having those people like Winta going out and taking those messages to communities has really made an impact. And I hope that all of this learning isn't forgotten as we go forward.
Tell me more. Maybe Winta, you could pick up on this point of the messenger being as important as the message, given that we're going into treatments and then into prognosis of our topic.
Yes.
You as doctors have such an important role to play, but also in your own communities. Tell me more about that.
Yeah, this is an excellent transition of a point that I thought would be important. I think, in terms of solutions, distrust of the medical system needs to be named. It needs to be named, and it needs to be addressed. Let me tell you some numbers, guys. I'm a numbers type of girl. All right, so 7 out of 10. This is a Commonwealth Fund study. 7 out of 10 Black Americans report being treated unfairly by the healthcare system. 70%. Okay. 53% of Black Americans do not trust the healthcare system. 55%. Did I say 53? 55%. 42% of Black Americans report that they would be willing to take the vaccine. That bothers me. 2021. And half of the people that look like me do not want anything to do with me. That is a problem, right? We have to be appalled. I took a Hippocratic oath to be, a servant of medicine, right? And like half of the people that looked like me, like basically think I'm poison and don't want to come near me. I was doing vaccine education with Azagadir on Clubhouse, and it was painful. I couldn't actually do it anymore. I had to stop because it was just, people were, calling me a messiah of 5G and I'm trying to kill everybody. And, me and Bill Gates are trying to kill everybody. And so, that I couldn't actually take it anymore. It was too difficult for me to do. Azagadir continues to do amazing vaccine education. And I couldn't do it. I had to take a time out because, being on the front lines, dealing with my kid being away from me, and also dealing with people calling me, an assassin, was too much. And so I think that, we really, as the medical profession needs to look in the mirror and see the ugly truth about the flaws that we propagate. We need to look in the mirror and say, you know what, we've done some bad things and we need to make them right. And it's difficult. It's difficult to have that degree of accountability and to notice your flaws. And I think that's where the change needs to start. I think it's not just COVID, Tuskegee was real, and it's not Tuskegee. It's like, people are experiencing structural racism all the time. My own mother, was told she had nothing on her breast for 1 year. 1 year. They said, it's nothing. Metastatic breast cancer, fully Mets all over her back, and I was too busy being a resident at Mass General to notice. And, I think that disparities in treatment and access, they're not fabricated, they're real. And, it seems like we have to yell and scream for people to believe that they are real, which is crazy. That's a crazy thing. I personally have actually gone through the medical system and experienced a lot of discrimination. That's why I decided to become a doctor, because I need a seat at the table, because I need my family to get the best access to care. And the only way I'm going to do that is from the inside, and so that's what motivated me to become a doctor. And so, I think that, distrust, people want to put distrust to the side. They want to say, let's just focus on being good. That is not enough. That is the model that we have used up until this day. Let's just focus on being excellent doctors. And that way that it'll just, the trust thing will just come. No, that doesn't work. You have to be really calculated and really diligent about, correcting the wrongdoings of structural racism in this country. You have to want to wipe it out. You have to want to say, we will have a zero tolerance policy to structural racism. A lot of people are not ready to do that, because they don't even believe that it exists. They think that we all act as good actors. We don't. We do a lot of terrible things to patients.
And there's a lot of context
totally
to what makes somebody go and see a doctor versus not. And it's not just that individual. It's, as you're naming, even your own experience of your mother's medical care, that's still in the back of your mind. And there's a question that we've got from somebody that I'd love to weave in, because it's a bit related to this, I think, which is about, we're talking about healthcare equity. Not everybody particularly marginalized people, particularly the poor, but it might also be somebody who's not able-bodied, somebody who's older, can easily access healthcare, and particularly with this move in the pandemic, digital health tools. And I'm thinking of the contact tracing apps that have been tried. I'm thinking of the COVID vaccine passports that have been discussed. They require people to have smartphones, which not everyone has. Sometimes they require people to have smartphones that are really up to date in order for the software to run. And I'm just kind of curious, because we were seeing those barriers to access before the pandemic. Now we're in the pandemic where it's telemedicine much more, and that's perhaps transformed and revolutionized healthcare in some ways, particularly accessing GPs. But even just as a pandemic tool and going forward, we've got about 10 minutes left. I'd like to take us into the future of, we're not out of this pandemic yet. We've still got a long way to go. We could turn it around and try to improve our performance, not just with vaccines, but with the other learnings we've had. What are your thoughts, both of you, based on what you're seeing about these barriers to access that are analog and digital? Feel free to run.
So for me, I would say that the kind of digital transformation has an opportunity to be a great leveler, but it also has the potential to heighten the divide. Just an example, today, my father, now you would have known in London, most of the parking, when to park your car, you now need to go via an app and try and park your car. So he can't do that. So already he will phone me or my wife and we'll have to try and park the car for him. So that's someone now who's had their independence when the pandemic, when things are easing, that now their kind of literally hard fought independence has then been taken away from them. And that's not just in getting around town. This is also in accessing patient services. So there's lots of things about digital transformation. How do we go to online first, etc. But there's going to be a lot of people that are left behind in that, in terms of how do they feel comfortable? Do they feel able? Can they rearrange their bookings online and what they're able to do? So we need to ensure that parity, that kind of is maintained and is achieved, rather than disparity occurring through digital transformation. I think that's number one. Number two is, look, we need to be honest about inequality and make some meaningful change. It's really poignant that we're having this conversation, and I think it's 4 years on since the Grenfell disaster, right? And in the UK. And if you all go onto Google or any search engine now and type in the collage of the people affected by Grenfell and the people that have been affected by the COVID pandemic, you could interpose the images. And I'm sorry to say that, right? And it's actually the people that those sections of society that we say that we need to help, we need to make some concerted effort to go out and help them. And if the pandemic doesn't do that, I don't know what else. So I'm hoping that will be a lightning rod in terms of us making some meaningful change in inequality. And the third thing for me is we've looked at New Zealand and the response there and kind of highlighted it as being, an exemplar. But one of the overriding things that I've seen from the kind of response and the leadership in New Zealand has been kindness and compassion. And I think that when we look on the TV and we look to leadership and we look at what's going on, that kindness, compassion from a country and a healthcare system, we need to get that. We need to get that right really quickly and ensure that all our healthcare workers continue now who are feeling burnt out. We need to try and help them heal and give them that space to do that. But society as a whole as well, I think we need that urgently in terms of people bringing us together and saying, okay, what does the future look like? Stephanie, the question that you've posed to us, I think we need a national conversation and some reconciliation about what's happened and how we go forward from that.
Thank you, Naeem. Winta, any thoughts from your side?
Yeah, I completely agree with Naeem. I mean, we have to break down silos across countries, silos across industries. We need to work together to literally change the way that we treat patients. That's what COVID has taught us. It says, you guys need to get it together, right? Because essentially, it showed the frailty of a lot of systems in America, a lot of systems in the UK, Canada, you know what I mean? It showed the resilience of other systems, right? That were smaller, that were able to do really well, right? We have, look at Israel and how much their amazing vaccine rates, like how they were able to respond, right? I mean, there's some A+ers out there, A+, I would give them A+, and then there's the C team. You know what I mean? And if I talk about the truth of the national response here, we're not in the A+. We're ranging towards C, B-, guys. You know what I mean? I mean, a B- is even a little bit grateful. I mean, I think we're a C. And so, I think America could do much better. And I think we're A+ quality, but we're not showing up A+ right now. And it has a lot to do with politics. You know what I mean? I'm not going to go on that rant, but geopolitical realities dictate what happens, in healthcare. Money dictates what happens in healthcare. And I think, technology also dictates what happens in healthcare. And what I think is that we all need to be working together to make healthcare a human right? That should just be a no-brainer, but it's not. And I think we need to be cross-sectional about it. I think we need economists at the table. We need technologists at the table. We need sociologists at the table. I mean, like whatever, you are the realest doctor. You know what I mean? I think that it's really important to have historians at the table. We have to revolutionize healthcare. And the way that we do that is cross-sectionality. And it has to be cross-sectionality because we as people don't exist in silos. We are part of communities. Your community predicates what happens to you. Your zip code in America, that decides if you have clean water or not. You should hear about the water problems that we're having in certain zip codes. You would think that we were, in another continent. Zip codes in America have sewage that looks like Africa in their drinking water. That is a real deal problem that's happening right now. 2021. Yeah. We should be so much better than this. This should not be where we are in 2021. This is like some 1811 existence for some zip codes, and that is not, we need to get everybody to the same place, regardless of money, regardless of religion, regardless of, creed, like everybody, every patient needs to be given the same opportunity. And we need to basically make sure that healthcare is a human right across the world. And so, in terms of, I think policies need to change. We need to break down silos and create cross-sectional partnerships. Institutes need to increase economic empowerment. We need to fund community programs that enhance neighborhood stability. We need to be consistent in efforts by health systems to build trust in vulnerable communities. We need to test and deploy targeted interventions that address social risk factors. And, medicine is not a silo, and doctors need to stop acting like medicine is a silo. It's not. Patients exist in their communities, and we need to be in their communities. I plan on being in the community, going to areas that people trust and saying, hey, I'm the new doctor in town. Like if you have a cancer, you need to take it out, come to me. But I'm not going to do it, from the comfort of my own office. I'm going to go to churches. I'm going to go to mosques. I'm going to go to barbershops, because that's where people already have trust, because they don't trust the building I live in anymore, which is crazy. That's crazy. It's crazy that they don't trust the hospital that I live in, so that needs to change. I think that we really need to break down barriers and just, work together. And there's a lot of, the beauty of COVID, in closing, is that it showed when you put some great minds together, you can get stuff done. That's the vaccine story. The world worked together. Patents all of a sudden didn't matter. People weren't worrying about not sharing because they're so competitive, right? Like we actually worked together. And now here we are, not, like the eye of the storm is a little bit behind us. And then we go back to our kind of, scarcity mindset ways. This is mine, this is yours. We have to continue to work together to address healthcare as a human right. We can't only do it in the eye of the storm. We got to do it every single day.
Winta, Naeem, this has been an absolutely superb conversation. And what I loved is we genuinely ended with a prognosis. I feel like we could type that laundry list up and send it to every government and the WHO and just say, here you go. So thank you so much. And thank you to our audience for questions and for watching.